We have not solved, not by a long shot, cervical cancer. If we have not yet solved that issue with vaccination and screening, people are still going to develop this disease and need treatment. And that's why Eve and I are focused on treatment, that internal radiation. And right now, the tools that are used for internal radiation brachytherapy are super painful. I know, I use them. They were designed in the 1970s before women were mandated to be included in clinical trials. And Eve and I, we refuse to believe that that's the pinnacle of innovation and of what's possible for the care of individuals with cervical cancers.
Hi, everyone. Welcome back. I'm Gabriel Allen Cummings.
And I'm Brad Davidson, and this is Breaking the Code,
a podcast series addressing misconceptions related to the discipline of behavioral science. We hope to arm you, our listeners, with the tools you need to make sense of behavioral science and help you apply it to your work as communication extraordinaires.
So as you guys can tell, Gabe will be Senika for the next couple of months. Senika is out on maternity leave. She said her goodbyes last episode. We miss her dearly, but without missing a beat, we've drafted Gabe into the Senika role, and he will be introducing our guest today, and you'll be having loads of opportunity to listen to Gabe in the next coming months. Very excited to do that. So Gabe, I won't say welcome. You've been on pretty much every podcast we've had, but welcome to the co-pilot's chair.
Thank you, Brad. The co-pilot chair does feel a little different than being a guest contributor to the podcast. So certainly interesting, and I hope that we can do well in Senika's absence.
There's a great Spanish expression that I love, which is it's not the same to speak of bulls as to be in the bull ring. So welcome to the bull ring. So anyway, and we're super excited for our guest today. So Gabe, why don't you kick it off?
Super excited is the best way to put it. We're joined by the founders of Mission Driven Tech. So I'm going to do a little reading of introductions here, first with Mission Driven Tech itself, the company, and then its founders. Mission Driven Tech is a new cervical cancer innovation company in collaboration with Weill Cornell Medicine. They are on a mission to eradicate cervical cancer by building inclusive products for people with a cervix and their providers who treat them. And today we are joined by its founders. Dr. Balogun is a world-renowned radiation oncologist and assistant professor of radiation oncology at Weill Cornell Medicine, who uses her rich clinical expertise to pave a new path forward in cervical cancer care. Eve McDavid is a former longtime Google executive, cervical cancer survivor, and global public advocate. They're hyping each other up right now. You won't be able to see it, but it's awesome. Eve uses her professional background and lived experience to fight for change in cervical cancer care. So first, to our guests, thank you so much for taking the time and welcome.
Thank you for having us.
Great to be here. Good morning, and thank you.
And a shout out to Jose Walewski, who gave us the heads up that this would be a good episode. So Mission Driven Tech, great name, love the idea. Tell us about it. What are we talking about here? What are we here today to? I know it's a little bit of inclusive design. It's a little bit of cervical cancer. It's a little bit of people with cervix. Let's just go from there.
Wonderful. Thank you so much, Brad and Gabriel. So Mission Driven Tech is a cervical cancer innovation company, and we are laser focused on improving the care continuum, starting with the field of treatment known as brachytherapy. Brachytherapy refers to powerful internal radiation procedures that cure cervical cancer. And we are on a mission to improve the state of care, to improve procedure safety, and to lift patient outcomes.
So what was the initial problem here? How did you guys get going down this path? Well, first of all, what's the solution, right? So I'll just ask the dumb question. I know the answer, but I want to hear you guys say it, right? So what have you done that's furthered the cause for brachytherapy?
Yeah, so what Eve and I have been working on for the past 2 years, and honestly, it doesn't even feel like 2 years. In a good way, it feels like much more has transpired. Basically, when we think of cervical cancer, there are, 3, maybe 4 pots or 4 distinct categories that we think about when we're looking at a means of eradicating this disease. So I think a lot of people know that in the WHO put forth an elimination initiative to eradicate cervical cancer, to eliminate it from the face of the earth, because it's one of the few cancers that we very much understand how it arises, and therefore we understand how we can get rid of it. So, just as a bit of background, the human papillomavirus is the most common sexually transmitted illness, and there are multiple types of it, but we know that there are certain types that account for basically 90% of cervical cancers. And so we have come up with a means of, one, prevention. So that's the first category, the vaccine. Not we as a mission-driven tech, but
Right.
exactly, the healthcare industry said, okay, here's this human papillomavirus that causes over 90% of cervical cancers. One, let's look at prevention. They came up with a vaccine. Two, there's screening, right? The Papa Nicolau test. He was at Weill Cornell Medicine. I always have to drop that historical fact. So there's the Papa Nicolau test, which is a means of screening and finding cervical cancer early. Then three, we have treatment, which is commonly either surgery if your cervical cancer is found early enough, or more commonly chemotherapy and radiation. And the treatment consists of 5 weeks of chemotherapy given on a weekly basis, as well as someone getting radiation from the outside, external pelvic radiation therapy. So, quick lesson, what's radiation therapy? I tell my patients it's kind of like x-rays that are a bit more powerful. It's energy being directed into your body, and the goal of that energy is to destroy the cancer cells. So, most people are not going to get surgery because their cancer hasn't been caught early enough. A lot of people are going to get chemo plus radiation, that initial 5 weeks that I talked about, and then they're going to get something called brachytherapy, the internal radiation. And then the fourth bucket we talk about is, survivorship, because that's key and that's important for people who've gone through cancer. We at Mission Driven Tech are focused on that third bucket of treatment, because honestly, a lot of people think that, oh, we have a vaccine for cervical cancer. We have an HPV vaccine. Everyone's getting it. Yay. We're all done. Unfortunately, that's not the case. If you
Yeah.
look at the rates, if you look at the rates worldwide, 641,000 cases, in the past year of cervical cancer, over 300,000 deaths. And when you look even at high income countries who should have access to this vaccine, we are sitting at best, in a lot of countries, like here in the States, we're at like a third of the viable population that can get vaccinated, being vaccinated. And especially when it comes to men getting vaccinated, both men and women should be getting vaccinated, ideally between the ages of 9 to 14. The vaccine is approved up to the age of 45, but especially men are not being vaccinated. So we have not solved, not by a long shot, cervical cancer. And so if we have not yet solved that issue with vaccination and screening, people are still going to develop this disease and need treatment. And that's why Eve and I are focused on treatment, which is that internal radiation. And right now, the tools that are used for internal radiation brachytherapy are super painful. I know. I use them. They were designed in the 1970s, before women were, mandated to be included in clinical trials. And the technology has not changed for over 50 years. And even I refuse to accept that the advances that have been made in brachytherapy, which include now inserting needles, sharp needles into the cervix, we refuse to believe that that's the pinnacle of innovation and of what's possible for the care of individuals with cervical cancer. So that's what Mission Driven Tech is about. We're on a mission to improve. Right now, we're focused on the treatment aspect, to improve that brachytherapy experience so that more individuals can be cured of their cervical cancer.
So I definitely want to talk about this solution some more. And it's funny, like in that whole thing, that whole synopsis, which was beautifully put together, like you touched on several subjects we've actually already done on podcasts. We did a whole podcast, for example, on why is the sex vaccine so taboo and why have we not managed to get further? And one of the
Because it's a
strange
cancer vaccine.
Yeah, exactly. Well, like, look, I mean, there were strategic choices made, right? Let's make it about cervical cancer, not head and neck cancer, or let's make it about girls, not everyone, right? Like that people sort of threw what they thought was a fastball down the middle, and instead it became a very contentious sort of policy and moral issue. And that's a real challenge, right? And I often say to people, like, you don't risk stratify tetanus. You don't look at children and go like, you look like you'll play with a rusty nail, right? But somehow it's become a sort of moral, like, oh, are you saying my daughter looks like somebody who might blank, right? That's a really challenging conversation. I think the other one that we've talked about quite a bit is inclusive design and women's pain. That, we had a whole episode, well, I was going to say not long ago, but it was probably longer than I think, kind of like you, Oni. Yeah, it was a little further back than I thought, but it's gone fast these 2 years. But just talking about the difference between disease versus illness, that there's a conceptual difference between focusing on eradicating pathophysiology and then going the next step, which is illness, which is the lived experience of the patient with disease. And it seems like what was invented 50 years ago does a great job taking care of the disease and a terrible job making the illness bearable. If you're nodding vigorously, so I'll let you take it from there, right? Is that really the gap that you saw and wanted to address?
Yeah, absolutely. And when you look at the data in this field, it's just extraordinary. So for 50 years, the 5-year survival rate outcome for cervical cancer has not budged. And that is an anomaly in cancer care, right? Think about all the incredible advancements in medicine and technology over the last 50 years. Our world does not look the same as it looked 50 years ago. And yet, the likelihood of survival from this preventable diagnosis is just as bad today as it was in the 70s. And you have that as a sort of starting point headline as, whoa, this is a big problem. And it's an even bigger problem when you put it against the context of what's happened in other fields of cancer research. And specifically, when we look at this from an equity standpoint and a gender equity standpoint, we've talked about the lack of women's participation in clinical trials until 1993. Well, over this same 50-year time period where cervical cancer outcomes are stagnant, prostate cancer outcomes, which were the same as cervical in the early 70s, have now advanced to almost 100% survival rate at the 5-year mark. And so to see a reproductive cancer that only affects males achieve gains to 100%, while a reproductive cancer that only affects females continue to kill women at the same rate as it did 50 years ago is just unconscionable. And so when you start to peel back what contributes to those stagnant outcomes, and we'll talk a lot about this with how we're working to improve brachytherapy treatment and the new medical device that we have invented and are designing, there are so many reasons why a woman can't get through care today to achieve cure and have a great quality of life outcome. But there's plenty of available technology that makes that possible. And that's what Dr. Balogun and I are really focused on. How can we bring the best of modern medicine and modern technology into this field so that persons with a cervix, when they have this diagnosis, unfortunately, for all the reasons that Oni described, late stage diagnoses, even in the US, have been rising for years now. And all of these cases will require brachytherapy for that individual to survive. Survival should not be based on whether someone can get through these procedures. Survival should be based on availability to access these procedures and have a consistently optimal treatment experience so that she can survive and thrive following treatment.
Right. I mean, it's interesting. Like, pain is one of those very contentious areas these days where there's sort of competing narratives that the opioid crisis has been driven by a promise of zero pain, which is impossible in real life. But this is different. That's not what we're talking about. We're talking about like avoidable pain that people could have had they cared or undergone this. They could have been dealing with this for a long time. I mean, I think this gets to the heart of inclusive design. So I guess I'll just throw it out there. Like, talk about inclusive design. What does that mean to you? And why isn't there more of it? And how does this represent a real success of inclusive design?
Yeah, so I'll talk about one aspect of inclusivity that Eve and I are thinking a lot about. I was born in a different country. I was born in Nigeria. And as a result, a lot of my career is working with international settings to improve their cancer care. And Eve and I are very aware that cervical cancer, the highest rates are not in North America. The highest
Mhm.
rates are in sub-Saharan Africa, in parts of Asia, in primarily in low and middle income countries where they don't have that infrastructure set up to regularly screen people, or much less talk about, giving the vaccine. So we want to put together, we while designing our medical device, we are very much focused on, is this going to be viable in a low middle income setting? Also, what we're thinking about is there are varied regimens for addressing pain, right? So we are very much aware. We started this. We started our company in part because of the extreme pain that is associated with the brachytherapy procedures. And we saw clear ways through intelligent design to decrease that pain. There are so many things that we can incorporate, features that we can change that will decrease the pain. And it's important because women's pain is frequently underestimated. And
Yes.
right now, in one center, you use general anesthesia. I use general anesthesia to place the device. In other centers, they may get a Xanax at best. In some centers, they say sorry, sorry, sorry repeatedly and just do it with nothing. So we want to really design this in such a way that if you, for some reason, do not have access to the best pain, regimen, you can still go through this procedure in a tolerable, humane way. So that's part of the inclusive design that Eve and I are thinking about, not just something that high income countries with lots of resources can use, but what can also low and middle income countries use. Oh, no, or even like rural settings, right? Because we know
Yeah.
even within high income countries, there's a urban rural divide.
Absolutely. And there's also cultural divides between the connected and disconnected, and the haves and the have-nots, and the,
Yes.
stigmatized and the destigmatized, or whoever. I think there's a lot of layers to who gets care, when, where, and how, especially this kind of intimate care, let's call it, right? Lots of issues of trust, lots of issues of, who's allowed when and where to look there, things like that. I think that's really important. It reminded me when Jose first brought this to us, it reminded Sanika and I, we had a conversation about these TikTok videos that girls are doing with the placement of their IUD. Because again, this is sort of women's pain, where women are told, like, it's just a little pinch, and then these girls are like, doing a TikTok of their face and like, doesn't look like a pinch to me, it looks like it actually hurts. So yeah.
Yeah, yeah.
Yeah, absolutely. And what you see in brachytherapy is emblematic of women's health across the board. So, what you just described with IUD placement and the minimizing of the painful experience and the assumption that a person is expected to tolerate it because this is just what you have to go through to be a woman. That is a consistent symptom across all of women's health. And in one way, it is helpful because you can see how damaging that trend is. And this is not an outlier, right? This is just another example of, we have not yet appreciated what a woman must go through in order to have these procedures.
I just want to say, when we say we mean men, because I think women appreciate women's pain, right? So there's like, if you're going to divide the world, like, I think women know that.
Absolutely. I mean, I think in general, perhaps, but I will say that there were things about my practice, right? When you are taught how you're taught in medicine, sometimes causes you to not be as sensitive.
Empathetic.
Yeah, sometimes, like, for instance, sexual health. I think of myself as a feminist. I think of myself as someone who really wants to advocate for women's rights. And it was only through working with Eve and looking at this with a fresh set of eyes that I realized, oh my God, I have been taught to really prioritize asking men about their sexual health. If they come in for prostate cancer, we have questionnaires that we give them, regularly to make sure that their sexual health is excellent. The questionnaires exist for women, but I had never been taught to implement them. So, I think, feeling of pain and saying, oh, this might hurt a little bit more. I might be sensitive to that, but there are other like gaps and blinders that the process of being um, taught how to practice medicine can put on, you know? I
That's
will share that.
I mean, you guys must have a theory, and I'm just curious, like, why don't we care more about women's pain? I mean, by we, I mean men. I do mean men there, right? So
Uh, there is a whole history that well documents the reasons why women have not been included, and specifically women's rights have been excluded in the development of modern medicine. What is really exciting is that over the last 10 years, there's been an enormous wave of change building in women's health, and right now, I think we're really start to hit a new high, a new like pinnacle point of this movement up into the right, where there is now much greater visibility into what it means to be a woman accessing the healthcare system that's designed for everyone to access in some capacity. Although, of course, that access greatly varies based on who you are and where you are and all the inequities that underpin that. But the representation of the patient experience has been something that only very recently has been focused on, and particularly in medical device design, the patient experience from the beginning is in terms of design and innovation, is a relatively new entry into the field. But when you think about building tools in medicine, you're building for two users. You're building for the practitioner who's using the instrument, and you're building for the patient who's experiencing that procedure or what that tool can do. And so by focusing on those two user sets, we can build something where medicine for women looks like partnership between the patient and the provider, versus this is something to be dealt with, this is something to be minimized, this is something to get through. And that's what Oni and I built our partnership on, was that we together were collaborating on what is the experience like for incredible physicians who don't have the best tools for the job, and what is the experience like for a patient who's just finding out at the end of first line treatment that she's about to go into the hardest part of this, and she might not be able to make it through because of the pain.
yeah.
And that looked like, what are you talking about? We can fix this. If we work together, we can solve this. And that's exactly what we're doing.
So just to add to what you were asking, Brad, about why do we not prioritize decreasing pain for women more? I'll say from a physician's perspective, we were focused on, oh, this is great. I talked about the needles, right? I talked about the needles previously. That's one of the innovations that has been brought forth for brachytherapy. Let's add needles that are placed directly into the tissue of the cervix. And people, including myself, oohed and awed at this and were very excited because it made the dose distribution. Like in radiation therapy, what we're concerned about is, are we going to get enough dose to the cervix to eradicate the disease, right? And we don't want to at the same time give a lot of dose to the nearby organs like the bladder.
Yeah,
and
you want to poison the tumor, not the host.
Exactly. So
Yeah.
people were like, myself included, were very taken by this idea of needles. And for years, I wasn't really thinking about the pain because we focused so much on, the disease, right? You were talking about. We focus so much on the disease and not the illness and the experience. And so I think that that was a fundamental barrier to innovation in this space.
I mean, to me, that's why I prefer the Oath of Maimonides. Not that I'm a doctor, but like when you read them, one of the first lines is, "Let me never forget that this is a fellow human being in pain." Right?
Mm,
That the Hippocratic Oath is very much a professional oath about code of
yeah,
conduct and what you owe
yeah,
to your colleagues and the
yeah.
gods and all that sort of stuff. The Oath of Maimonides is what you owe to your patient, and like they're a human in pain. And it is interesting. There's parallels, right? People get trained to Clinicians, doctors really get trained to think about the outcome as the goal.
Yeah.
And if you have to get through the experience, that's your job in this equation, right? You get through it. I'll cure you. You get through it and we'll be done in the end. And I remember having a quasi argument with someone who was in my dissertation study about, I'm a linguist by training, right? And I remember him saying, if I took twice as long with every patient and they liked me better, would they
Mhm.
actually do better? Or am I doing a better job for society by being rude or perceived as rude, but seeing
Mm.
twice as many patients and they're all doing just as good? And I was like, the lie in that is that they're not all doing just as good, because half of those patients to whom you're rude are not coming back, right? And I know that because I interview them afterwards and they don't like you. I didn't
Right.
say that. I couldn't say that to his face. I was 26 years old or something like that. This guy was
No,
a
but
pretty important doctor, but yeah.
that's a really good point, because I was thinking, oh, he's seeing them twice as fast, but we see it. If you take the time to sit with a person and talk to them, there are things they will tell you and uncover, right,
Yeah.
that you didn't know before. I just had a recent experience where someone came in supposedly for routine screening for one part of their body, and talking to her, giving her the time, she opened up and said, actually, what I've been noticing is a problem with this part of my body,
Right.
at the end of the visit, because I like to think she gauged that, okay, I actually cared and I was going to listen and
This
take
is an
her.
audience who won't judge me. This is an audience who
Exactly.
will, whatever. I
Exactly.
remember some of the stuff that people have heard from their gynecologists. I've been married a long time. Like, some of what's said in a clinical way doesn't jibe with people's own experiences of owning the sort of plumbing that we're talking about. And it's when those happen, like, you just try and find a new OB, basically.
Oh, you have to consider that there is an inherent power dynamic in the exam room between the patient and the doctor.
Sure.
One person in that room has all of the education and information about what's happening. And then the other person in the room is experiencing some symptoms or feelings or experiences that they might not be sure of how to express or communicate. And that can be a really difficult 15 minutes to
Right.
establish trust, confidence, and then use your voice. And
Well,
so, a
listen,
lot of what happens in cervical cancer screening and these challenges around follow up is that, first of all, women have no education that the HPV virus causes cervical cancer, right? There's only 17 states in this country that require sex ed to be medically accurate. And so, oftentimes, the first time someone figures out or learns that cervical cancer is caused by HPV is at their first gynecologist appointment when they're diagnosed with HPV. And they might find out that they have a high risk strain that puts them at risk for developing cancer. And it's like, how many steps got missed before that information was conveyed? And what do you think happens to the confidence of that patient finding out that she has an STI that could cause cancer? And now she's trying to figure out how to articulate her fear and what that might mean for her in the next 15 minutes that she has with her provider. It's
so this is
unrealistic,
something,
right?
yeah,
And
this is
that
something we talk about a
happens
lot, is this sort of
every
yeah.
field. Exactly.
This sort of conveyor belt medicine is very, very effective at throughput, which is very popular for people who are running the numbers on hospitals, but it's not very effective for getting people to talk about their fears, about the really sort of like deep, shameful parts of things. I mean, we're talking about parts of the body that have some real sort of heavy associations. And, I've certainly had girlfriends who felt shamed by gynecologists when they answered routine questions about their sexual
These are,
practices and stuff like
yeah,
that. Yeah.
and these are normal parts of the body for half of the world's population. And many women don't have the proper words, not because they don't know the words vagina or cervix or uterus. It's because we don't teach them, right? They don't get taught in schools. They don't get taught at home. We have other words that we use that connote shame, that make it feel shameful to talk about our bodies. And so, if we don't even have the words to say, hey, I'm experiencing abnormal bleeding, or my
Right.
vagina does not feel the way that it typically feels, if we don't have this language, then it isn't coming out necessarily in an environment where you're just trying to figure out, like, how do I make sure that I'm doing as best as I can to be here and get the care that I need, but I don't even really know how to properly.
Look, the whole process for many people is intimidating because the institution itself is intimidating. You mentioned that doctors have all the knowledge. Even doctors who become patients lose a lot of power and find it very disorienting. I think it's a mistake to think that it's only the knowledge that's keeping people at bay. The whole thing is designed. You are a consumer. You are a body when you are in a hospital, and the institutional practices around the medical interview put the doctor in charge because they're the one who's been given the authority to say when the interview starts and stops, when we've gotten to a conclusion. Like, there's tons of dynamics. I see Oni sort of nodding. Like, it's interesting. I'm happy we can have a different discussion about this, but the dynamics of the medical interview really turn the patient into an object that is a resource for basic information. And it's the doctor or the clinician who is then sort of in charge of sifting through that data and saying, this is what's going on. And that's where I think the sort of patient-centric medicine challenges that, but doctors aren't very well trained on how to do that. So
I have to, I agree with you on some level. I think what you just touched on, the patient-centered care, that is something, shout out to Yale School of Medicine. I'm a product. They
go New Haven,
really,
bula bula.
they really try to talk about shared power, right?
Right.
You ask the person, what are your priorities for this visit? I'm
Right.
not sure how many people still continue to visit, but those things are in me. Like, do you have any other questions? What else is there?
Right.
So
Well,
I
and
think
Kaiser teaches like invest in the
Yeah.
beginning, right? Like the four habits. Like the first one is like, is that everything you're concerned about today? Which of these is the priority kind of stuff? Yeah.
with medicine, as it was practiced probably, maybe 2 decades ago, was a lot more paternalistic. I'm glad to see more institutions are trying to share that, power. It should be a collaboration. And that's what I love about Eve and I and the work that we do together. I don't, it's not common for medical devices to have this, physician, survivor advocate, collaborative lens. And I think that's one thing that we bring. And I actually wanted Eve to talk about Brachy stories. This is one of her brainchild.
Yeah.
While we're getting into this work, there's so many gaps. There's not a lot talked about the women who stop treatment with brachytherapy because of the pain. There's just not much out there. So Eve, you came up with Brachy stories, and I think that's one of the things that's going to demystify this
Yeah.
field.
Yeah, absolutely. And this part is so important because it involves surfacing voices of survivors from around the world to understand what their experiences are in brachytherapy and how they have lived in the aftermath and what they would have liked to see in their care and how they feel women should be treated going through these procedures. And what it is helping to illuminate for us is a roadmap for all the improvements in this care continuum that also include the introduction of a new medical device that reduces the pain and the trauma and improves the procedure safety, but also touches on the need for upfront communication about what these procedures will entail so that a person is able to get ready. And readiness is connected to empowerment, and empowerment is connected to the ability to endure and get through. The next piece, which Oni has talked a lot about, is this heterogeneous approach to pain control, where in some clinics, women have full anesthesia. In others, they have very little pain control. And we're talking about a procedure that might last up to 10 hours, where a surgical instrument is inserted in a woman's body and she is awake for the majority of that time. And so to not have a consistent and appropriate pain control schedule here is one of the key reasons that women do not come back. These procedures must be repeated every 2 to 3 days for about 3 weeks. So you're going to have 5 of these. disease, and if you go to your first one and you have no pain control, and it's the worst thing that you might have experienced in terms of pain and trauma in your life, you might not come back. And that happens 40% of the time in the cure for cancer, right? 40% of the time, people who embark on treatment that will cure their disease drop out. And unfortunately, they drop out knowing that their disease not only won't be cured, but it will recur and they will die from their disease. And Oni has shared stories of what she's experienced in her practice of women who begin and do not complete. And it's gruesome and it's horrifying and it's unconscionable. And so what we've sought to capture in this research are simple pieces of information, language, and processes like consistent pain control that can be applied in practice today, so we can start to improve brachytherapy care for patients and providers now, while in time, our new medical device, the Blossom, will be ready for use in practice. And this, for us, is a natural evolution of the field. It's change that starts from the inside out. It's informed by the lived experience and also providers who are administering these procedures. And the goal is to put everyone on the same page, give everyone the same playbook of what brachytherapy is and how to get through optimally, all while innovation is coming in the field.
And I'm so glad you brought that up, because one of the things we found when researching your story was this idea of women, quote unquote, choosing death over continuing brachytherapy. And one of the things with breaking the code is that we talk about empathy and we talk about having an understanding. We talk about the decisions that people make may not always make sense to everyone. So when someone hears choosing death, they're like, how could you ever choose death over this pain? And so I'm glad you went into it from that perspective. One thing that we've brought up a few times over the course of the conversation was this brachytherapy tool that Mission Driven Tech is working on. So could you expand more on that? And also, could you also share the mindset of women who choose death over current treatment, while talking about, of course, the Blossom as well?
Yeah, absolutely. So this has been well documented in the medical literature. There are studies on the patient experience where women are quoted about what brachytherapy has felt like to them. And women are quoted saying, I would rather die than have brachytherapy procedures. And from the data that we see in attrition from treatment, dropout from the treatment protocol, that is confirmed. Now, Gabe, to your other question about the medical device that we're developing, this is all incredibly connected, right? If at a decision point, someone is dropping out from care versus being treated, well, why is that happening? In the medical research, you see that the insertion of the medical device, because of, again, the inconsistent pain management and the removal of the medical device, are two of the areas that cause the greatest distress and anxiety for patients going through these procedures. And so we thought about that as a starting point. What would it look like if the insertion and removal of this medical device was actually properly fitted to the female anatomy? So it could move with agility, it could be adjustable, it could be flexible, it could almost work like a tampon for insertion and removal. And what would that look like? And the really incredible thing about, designing in a field that needs some modern innovation to be brought in is that there are great examples of this type of functionality from an engineering perspective that already exists in other medical devices that are in use throughout other fields of practice. And so what we've designed in the Blossom is basically bringing in modern engineering features to enable dynamicism, flexibility, and then the ability to better navigate through placement, so that we're avoiding things like uterine perforation, which is a common complication that happens during placement today because of the lack of visualization and the lack of feedback. So basically, we have identified the literal pain points that exist in the practice today and incorporated those into our engineering design. We are in the process of prototype development and testing of the Blossom right now, and that work is ongoing, but our development work and testing results have been incredibly promising to date and are very encouraging of the ability to create this type of tool that is similar enough that it is, from an adoption perspective, it isn't such a departure from what a clinic and a physician are familiar with, but it is designed for optimal care, safer care, and to greatly reduce those complications that again lead to the dropout from care and the inability to reach cure and survive.
Yeah, and then Gabe, when you asked about choosing death, I'll say the women that I have seen not complete treatment, it's a choice to not complete treatment, and I don't fault them, but it haunts me because as soon as I see them not coming back again, I know what's going to happen. It has played out several times in my clinic. Some months later, I get a phone call, there are complications, or the person is dying because the cancer came back. And I don't fault them because some of them stop because the pain, is great. One of them stopped because she was so scared of us pulling out, even pulling out or removing the device, not to mention placing it. At the end of the procedure, a lot of people don't use anesthesia again because once you give anesthesia, you have to wait a certain period of time. It adds time to the process. And she was terrified. I had to convince her. I had to spend over an hour convincing her to let me remove this device. So I see clearly the reasons why someone does it, and I don't fault them. That's why I think it's up to us, up to people like Eve and I who see this problem to put our heads together and say, how can we do better? This cannot be the pinnacle of innovation for women's health and cervical cancer treatment. What else can be done so that individuals can access the care, can go through a humane treatment process and finish without the specter of pain just kind of looming at every corner? So they make the best choice for themselves, which is I cannot take this pain anymore, and I'm not going to subject myself to it. And I can't fault them for that, but there are dire consequences as a result.
Yeah, and thank you for sharing that. I just think that there are some times where there's when it comes to health, we get a little frantic, we get a little antsy, especially when it's like when someone else is making a decision for themselves, and it's like, why don't you just choose the thing to, in this case, live? That concept of choosing death is just it really captured for me what was so dire and why the work you're doing is so needed and urgent right now. And I'm gonna keep an eye on the clock because Brad, I feel like we could have them for another hour.
Well,
But
I mean, this is welcome to the co-pilot's chair. Like, yeah, we often find ourselves incapable of ending in a timely fashion because these things just keep going. They're so interesting. And I mean, I haven't even gotten to ask you guys what I grew up, my grandfather was a urologic surgeon, and we have his instruments in a glass case, and they look horrible. Every time I look at them, I'm like, I don't ever want to need one of these big old brass cystoscopes and stuff like that. I mean, we
You
never
could
even
show
really.
them to us and we wouldn't even flinch.
Yeah, I know. That's the men are definitely not prepared for these things. But, I think some of the visuals I wanted to talk about and the design. So maybe we'll have you guys back on and we'll really we'll talk through the design process itself. We'd love to hear how you landed where you landed, how you made the decisions you made. Was it big design choices, or was it literally like, oh, you want it without pain? We could have done that all along. Like who? Yeah, so, oh, we had no idea. So, but
Yeah.
I do want to thank you both for coming on. It's been incredibly difficult to schedule you, and you're busy for such a good reason. You're doing such good work.
just wanted to give them one more question, just very broadly, very generally. We do like to give the guest like the floor for the final word. So
Yep.
we were just curious, like, what's next for Mission Driven Tech, and what's the best way for our listeners to reach out and help? This is definitely one, like, for our listeners to like share with a friend, maybe someone who's never listened to Breaking the Code before, but not for us. For Eve and Oni and the work that they're doing is.
Yeah.
I'll give you the final word. I'll keep it as broad as possible. The floor is yours.
Great. Thank you. The first thing that I'll say is that this is not a drill. If you are hearing this podcast and if you have ever had an abnormal pap test, or if you've ever had any reason to have some sort of cervical health intervention and care, please, please, please listen up. if you are diagnosed today with a 1B or later staging diagnosis, you will need brachytherapy to survive. And as challenging as that concept is, it is the reality for many women in this country and many women around the world. And the understanding that this is what's required for your survival, after hearing everything that we've discussed, hopefully is activating enough for you to want to be part of this change. We do this work to spotlight this critical unmet care need that exists in brachytherapy, to make this field more visible so that it can improve and innovation can happen and that can accelerate. And the way that happens is through funding. Medicine does not advance without scientific research, which costs money. And that research is what creates breakthroughs, new technology, and innovation that advances the field. And so, as powerful as our work is, we cannot do it alone. And we are among the cohort of female-founded women's health companies that only receive $2 for every $100 that are invested in startup companies. And so if this message in what we're doing at Mission Driven Tech resonates with you, if what we've shared about you about the current state of care and how we're innovating, we encourage you to visit our website, missiondriventech.com. I think it'll be in the show notes. We have an active crowdfunding campaign where individuals can make contributions to advance our work. And that crowdfunding campaign is featured on our website. So if you heard this, if you're moved and you'd like to make a contribution, we would love your support in helping us bring our work to light through our crowdfunding campaign.
We'd also love for you to amplify our message. We are very active on LinkedIn. So you have a lot of communicators who listen to Breaking the Code, and we would love for them to help repost our messages, share it with your networks, so that the wider this message is spread, the more likely we are going to, get that drumbeat amplified so that we can really make a change and get into the ears of the right people.
This is great, and honestly, I can't thank you guys enough for both giving us the time and then also just the work you do. It's just so important. It's really inspiring. It's one of the best things about this podcast is we get to talk to interesting, dedicated, mission-driven people. And I just want to say, it's been awesome. Thank you so much for making the time. Really, really, really just eye-opening, just tons of food for thought. So thank you very much.
Thank you all. Thank you, Gabriel. Thanks, Brad. Thanks, Sonika. And
Thank
good luck.
All right. So on behalf of Breaking the Code, I'm Brad Davidson.
And I'm Gabriel Allen Cummings. Thanks for listening, everyone.
Bye, guys.
Breaking the Code is a podcast created and produced by Havas Health and U's Medical Anthropology Department. Hosted by Brad Davidson and Sonika Garcia. Content and post-production audio editing done by Gabriel Allen Cummings. And inspiration from all of you. And for your continued support. If you enjoy these episodes, we would love to hear from you. Please leave a rating, subscribe, and send us a message to our mailbox at medicalanthropology@havas.com. Until next time.